Hi, my name is Dr. Nafach. I'm going to one. So why is that an important issue? Well, we have to remember that the number of diabetic has been increasing proportionally. As we're speaking, there's about 148 million Muslims with diabetes. Now, despite all this exemption that some patients has high or very high risk of hypoglycemia, the vast majority do fast the whole month of Ramadan. Now, the number of diabetic is increasing proportionally, but in our area, especially the Middle East and North Africa, is going to have one of the highest increase in the number of diabetic that's going to increase from now till 2045. And that, of course, will reflect that they're going to have more diabetic that's going to fast in Ramadan. So we have to deal with the risk or the complication associated with it. And that includes that there's increased risk of hypoglycemia. And of course, we have to be careful, especially using agents that increase risk of hypoglycemia, such as sulfonylurea and insulin. Of course, there's many studies, and one of them, for example, showed that 40% of the patients do experience risk of hypoglycemia, and that's a risk we have to maneuver in preparation before Ramadan. One other thing that patients with diabetic have a higher risk of high glucose. They have a higher risk of higher cholesterol, ketoacidosis, thrombosis, and dehydration. And most likely, the increased risk of thrombosis is related to increased dehydration. So when it comes to using oral semaglutide being somewhat a new agent or new GLP-1 on the block, we have to remember it's a new novel GLP-1 that's available that has to be taken a certain way. It is indicated to use on top of diet and exercise on patient uncontrolled, usually with metformin. But one thing that we're going to have challenge with in Ramadan is the fact that we need to fast for 12 to 14 hours. The patient has to take the drug, usually 30 minutes, and wait a whole 30 minutes before they can take medication. I'm sorry, before they eat food or take any other medication. And of course, that's a difficult task to do, especially that the rest of the family is gathered to eat iftar. And so this study that I'm going to present is going to address, try to get, let's see what kind of scientific evidence we have to try to see what can we do on the patient who's receiving oral semaglutide, what benefit we get with it, any risk associated with using the drug, and look at the A1C, the weight change, and the safety parameter. So we're looking at different parameters related to using the medication. So it is a significant study because really it is the first one that's really aimed to address this issue of looking at using oral semaglutide in Ramadan. It has a significant implication in healthcare because for us as a physician, we need to know how to answer the patient or advise the patient when they come to meet us in a sense of seeing what adjustment need to be done if they're going to use oral semaglutide, and then explain to the patient what we need, how to take the medication. Now, if you go first to the label of, originally, how should we take oral semaglutide? Well, oral semaglutide should be taken on empty stomach. Usually it's a pretty small pill and you have to take it with half a cup of water, should not exceed mainly 120 ml. If you go higher volume, that could affect the absorption. And then after taking the pill, we have to wait for 30 minutes before we eat or drink or take any other oral medication. Usually what we do is we're going to start with 3 milligram, do it for a whole month, then you go up to 7 milligram, and then you do the 7 milligram either for 1 month or more based on the glycemic control for the patient. And then you can advance the treatment if needed to 40 milligram. And of course, that depends on tolerability. Now, when it comes to Ramadan, logically, you want the patient at iftar time to take the oral semaglutide with 120 ml water, wait 30 minutes in the Maghrib, then eat their meal, despite the fact that the rest of the families already had ate. So that kind of was a question that needed to be addressed by the study because there's a lot of possible deviation that you could have seen in patient intake. The patient may refuse to take it at iftar and they decide to take it at pre-suhoor. The absorption of the pill may be affected if patient drink a lot of water. We know that already from pharmacodynamic studies because again, patient may be very thirsty. there's a possibility that the patient did not take it on empty stomach, and then the patient may not wait the 30 minutes. And to address that, we have this kind of a unique trial. We were part of the site, which called OC-Nafast. So it's prospective, non-interventional study that investigating glycemic control, body weight, treatment pattern, dosing compliance, and safety parameter using once daily oral semaglutide in type 2 diabetics who intend to fast during the holy month of Ramadan in a setting in UAE, Saudi, and Kuwait. Now, there is primary endpoint and secondary endpoint. Of course, the primary endpoint, usually the majority of the trial, is the change in the A1C. And then there's a lot of other points, including the weight, the hypoglycemic effect, the GI side effect, and all that. And of course, we're not going to address all of this. But one of the other secondary points that I'm going to show here in the slides is, was there any change in the dose? Was there any change in the waiting time in the intake of the pill? And again, the trial patient has to be on maintenance dose, so mainly 7 or 14 milligram at least 4 weeks. And then they go to the entrance period, then they go to Ramadan, then the follow-up trial. And again, as we indicated, is non-interventional trial. There was some exclusion, of course, being type 1, patients who are pregnant or planning to be pregnant, breastfeeding, or who were on insulin within 2 weeks of the enrollment. When you look at the demographic of the patient, you can see very clearly that about 60% of the patient were male. The average age is about 52, and there is a distribution of the age, some younger population and some are not. Now, when you look at the duration of the diabetes, again, you can see that big part of the patient has a long duration of diabetes, being over 6 to 10 years old, and they're kind of evenly distributed. So we remember that, again, big part of the patient who receive GLP-1 usually tend to be diabetic for a period of time more than 3-4 years. Now, when you look at the dose of semaglutide, you have to remember, again, patients started with 3, then went to maintenance road, that dose which is either 7 or eventually 14. Then while they are on a stable dose for at least 1 month, then they enrolled in the trial. So the patient either were taking 7 milligram, which is, or 14 milligram, and almost half of the patient were receiving each of the dose. Now, if you look at the other concomitant medication, you can see that metformin was about 88% of the patient. DPP-4 is 16%. Again, we have to remember that typically you should not take it in the same time with DPP-4. You had a very high penetration of SGLT2 in this population, was 83%, sulfonylurea 30%, TZD 7%. Now, when we look at the outcome, in a sense of saying, how was the dose of semaglutide? And you can see that there was about 50% or so of patients receiving 14 milligram. Now you can see there was about 8% who was receiving both doses, which means that during Ramadan, they changed sometime between 7 and 14. And you can see that post-Ramadan, there was a little bit higher percentage of those patients who received the 14 milligram and less of the patient who received both doses. Now we try to look at the data saying, do we have patient really waiting at least 30 minutes after taking oral semaglutide? Now here, we're not talking about being iftar or non-iftar. It's just the idea of, did they wait the 30 minutes? And the answer, 92% was pre-Ramadan. During Ramadan, it went down a little bit to 80%, and then back to 91% after Ramadan. But again, even in Ramadan, which is the big concern, the vast majority of patients actually did wait the 30 minutes. The other point is, did they take it with a little bit of water? As you remember, a patient could have been so thirsty and take too much water. And the answer is really the vast majority, again, 85%, pre and post and during Ramadan, did take it with only 120 ml of water, and even the rate went up higher. But again, the majority of patients were compliant on that. Did they take it on empty stomach? And the answer, again, 90% plus, pre-Ramadan, during Ramadan, and post-Ramadan. So you can see here very clearly that the patient were very committed in this trial, despite the fact that it is very inconvenient in a way that you're going to take the pill and wait 30 minutes. But patients were willing to do it. Now, again, not everybody took it at iftar. And so here you can see on the left side, pre-Ramadan, and you can see that 89% of the patient took it early in the morning after waking up. During Ramadan, you can see that 72% the dark blue were taking it at iftar, but you have about 24% that took at suhoor, actually. And then post-Ramadan, they went back to take it early in the morning. Now, was there any worsening in the glycemic control? And the answer is no. Actually, there was very little, but an improvement in the A1C of 0.2%. The second question is, did all this variability that we see with the patient, that some of them took at suhoor, mainly quarter of the patient, has any effect whatsoever? And actual is no. When you look at it, actually, patient lost further weight when you look at the trial. And even if you look in the absolute weight loss, there was 2.6 kilogram weight loss. One important part is the safety. Again, do we see any increased risk of hypoglycemia? Do we see any other concern? So when you look at the hypoglycemia, again, we have to go slowly over this slide. So on pre-Ramadan, again, this is the data collected from the patient who came with diarrhea, or they recorded the diarrhea. You know, some patients, sometimes they did not recall all the time. Some of them, they record more during Ramadan. So what you see here on the left side on pre-Ramadan, there was 129 patient that really recorded their diary, so we can depend on it. And there was 9% of patients who experienced hypoglycemia, and 91% of the patient did not. In Ramadan, the rate of hypoglycemia, or the patient who experienced hypoglycemia, went up to 24%. Now, again, you have to remember they kept more track. You can see that there was 215 patients who did record their diary. And then post-Ramadan, again, the number dropped to 130, and only 10% did record hypoglycemia. So as it seems here that there is an increase in the event of hypoglycemia during Ramadan, which again confirm what we already know about that in that perspective. Now, all the hypoglycemia was minor, mild. There was no severe hypoglycemia whatsoever. So we can see here again that usually in Ramadan, there was an increased risk of hypoglycemia as expected. Now, this is really the severity, so mainly mild and moderate. There is no severe. And you can see here that when you look at the causation or that is it related to taking the drug, and again, probably it's related to it. And you have to remember, a lot of those patients actually may were on sulfonylurea while taking this medication, and patient really recovered very nicely. Now, if you're trying to summarize this data, what you can say is that number one, we have this data that showed very clearly that using oral semaglutide is a safe option, that you can take it without worsening A1C. There was a very mild improvement of 0.2%. There was a weight loss of 2.6 kilogram. The drug was well tolerated. There was a discontinuation rate of 7%. Very few patients discontinued due to GI side effect. And there was an increased risk of hypoglycemia in Ramadan. Again, part of it, those patients were receiving sulfonylurea. We can see that a bigger number received 14 milligram. Some patients did switch between 7 and 14. And you remember in this study, we had very high penetration of those patients who received an SGLT to 80% plus. So this study support that we have an oral GLP-1 as a safe alternative to treat those patients without having such a high risk of worsening of glycemic control. I need to add, and when they tried to kind of subgroup analysis, again, I don't have the slide for it, but you remember there was a percentage of patients who took it at iftar. They did not see as much worsening glycemic control. So in a sense that if a patient does not want to wait the 30 minutes at iftar, there is a likelihood some patient will eat at iftar and then don't eat for 5-6 hours till suhoor. Then at that time, they kind of have an empty stomach. They can actually take the oral semaglutide and 30 minutes later eat their suhoor and then go to bed. And I would stop at this point. I would thank you for taking the time to listen to the presentation.